Assalamu alaikum wa rahmatullahi wa barakatuh. Today we have a new subject on pediatric surgery made easy about an important disease for all pediatric surgeons. We will speak about the Hirschspurung disease. Let's start. Hirschspurung disease, an important topic in pediatric surgery for all pediatric surgeons. The objective will be the definition of the Hirschspurung disease. What is Hirschspurung disease? What about the pathogenesis of the disease? How to manage, and what you will do with a child not doing well after Hirschspurung disease surgery. At first, what is Hirschspurung disease? Hirschspurung disease is a congenital disorder affecting the enteric nervous system, which is the nervous system responsible for the innervation and motility of the gastrointestinal tract. This disorder characterized by absence of the ganglion cells in both myenteric and submucosal plexus. There are two plexus of nerves in the gastrointestinal tract controlling the motility and the innervation. Both plexus formed of ganglionated nerve. Both plexus are affected in the Hirschspurung disease. This affection will result in absence of the peristalsis in the affected segment of the bowel with functional intestinal obstruction. The incidence of the disease is about 1 in every 5,000 live births, about 80% affecting the rectum or the rectosigmoid part of the gastrointestinal tract. However, there is about 5% affecting the whole core and called total colonic aganglionosis, and very rarely maybe near total intestinal aganglionosis with affection extending to the small bowel. The syndromes that may be associated with Hirschspurung disease include the trisomy 21, the congenital hypoventilation syndrome, neurofibromatosis, and neuroblastoma. These syndromes are related, some of them embryologically related to the absence of the what's called neural crest cells or neurocrystomasis. What is the pathophysiology of the Hirschspurung disease? The basic pathophysiological feature of the Hirschspurung disease is the absence of the ganglia, with the presence of spastic and narrow aganglionic segment of the gut. This spastic and narrow segment prevent the propagation of the peristaltic waves and resulting in functional intestinal obstruction. So what is the explanation for the presence of this spastic or tonically contracted segment? Is the absence of the ganglia responsible for this pathology or pathophysiology? No, it is not the only one. There are many contributing factors responsible for this spasm or tonically contracted segment, which will lead to arrest of the peristalsis and functional intestinal obstruction. At first, we must know what is the normal gastrointestinal system motility and innervation. The normal motility and innervation depend on the autonomic nervous system. Autonomic nervous system with 3 divisions: the enteric nervous system, parasympathetic and sympathetic nervous system. The enteric nervous system is a unique system supplying the gastrointestinal tract. It contains millions of nerves like that in the spinal cord. So this system is very important for gastrointestinal motility and movement. The enteric nervous system is formed of 3 elements, very important. 2 ganglionated plexus, we mean by ganglionated, contain ganglia, nerve and neurons and ganglia, called the myenteric and the submucosal. Myenteric present between 2 layers of the muscles. The gastrointestinal tract, there is 2 layers of the smooth muscle, one longitudinal and one circular. In between these 2 layers, there is myenteric plexus of nerves, and in the submucosa, there is submucosal plexus of nerve. Number 2, an important element is what is called interstitial cell of Kajau. These cells act as a pacemaker, mediate the neurotransmission between the nerve and between the muscle through gap junction. So this cell responsible for the mediation of the motor neurotransmission. And the third type is in the gastrointestinal tract. There are two types: cholinergic nerve fibers, which is excitatory fiber acting with release of the acetylcholine, and the adrenergic nerve fiber, which is inhibitory, act with the release of nitric oxide. And maybe third type called non-cholinergic, non-adrenergic. So this three element is very important for the function of the enteric nervous system. If there is any disturbance in these three elements, the enteric nervous system will not work, and there is arrest of the peristalsis with proximal dilatation and the presence of the spasm or spastic segment. Then the parasympathetic and the sympathetic nervous flow supply the gastrointestinal tract, as all of us know that the vagus and the pelvic nerve supply the distal intestinal segment, and the sympathetic supply the whole gastrointestinal through post-ganglionic fibers. This anatomical arrangement of the enteric nervous system and the connection with the sympathetic and the parasympathetic systems result in the presence of two reflexes, which is called peristaltic reflex or law of the gut, and the Rictoanal inhibitory reflex. Peristaltic reflex means that normally gastrointestinal distension initiates peristalsis by making a contraction which began at the proximal side of the distended segment here, and the relaxation on the distal to the distended segment. This contraction mediated with the release of acetylcholine and the relaxation with the release of nitric oxide. So this is called peristaltic reflex or law of the gut. Normal physiological reflex allow for propagation of the intestinal content. Also, there is what's called Rictoanal inhibitory reflex. What this means? That rectal distension result in relaxation of the internal anal sphincter. This relaxation is very important as a part of the defecation reflex. This reflex is lost in Hirschspurung disease children. So the children with Hirschspurung lack this reflex. Rectal distension don't produce reflex relaxation of the internal anal sphincter. So the question now, what is abnormal in Hirschspurung disease? Number one, aganglionosis. Yes, from the definition of the disease, it is characterized by the absence of the ganglia. Number two, there is maybe abnormalities also in the cholinergic innervation, adrenergic innervation, in the interstitial cell of Kagel, in the abnormal smooth muscles, the smooth muscle, in the proximal ganglionic segment, or abnormalities in the motility. All these items could explain the pathophysiology of the disease, the presence of the spasm or spastic segment, the absence or lack of the peristalsis, the presence of the dilated segment proximal to the obstruction. The aganglionosis, we know that the neurons and the ganglia of the enteric nervous system embryologically derived from what is called neural crest cell. What's neural crest? It is a peripheral part of the neural tube. After formation of the folding of the neural tube, the peripheral edges of the neural tube form the neural crest. And then the cells from the neural tube or neural crest migrating all through the gastrointestinal tract. They are found at the 5th week to appear in the esophagus, and then at about the 12 to 13 weeks migrate to the anal canal. These neural crest cells will differentiate to form the ganglion cells. So, if there is failure of the migrations of the neural crest cells, or on the other hand, early maturation or differentiation into the ganglion cells. So there is a part of the gastrointestinal tract don't contain the ganglion cells. So the first problem which may happen in Hirschspurung is a failure of the migration of these neural crest cells, or its early maturation or differentiation. So the neural crest didn't reach the distal intestine. And you can imagine that earlier arrest of the migration equal longer aganglionic segment. Number two, there is maybe failure of the development after migration. We mean that the neural crest cell, which arise from the edge of the neural tube, migrate to the whole gastrointestinal tract. However, in certain area, they fail to survive or to proliferate or differentiate, maybe due to microenvironment, unsusceptible environment, due to abnormal composition of the extracellular matrix in the aganglionic gut, and this result in aganglionosis. The third theory trying to explain the aganglionosis is ischemic theory. The neural crest cells successively migrate, but later destroyed due to ischemia. And they explain this by the presence of what's called zonal aganglionosis or acquired aganglionosis or acquired hypoganglionosis. Area with normal ganglia then become hypoganglionic or aganglionic. They attribute this to that there may be some event of ischemia or abnormal vascular supply. Maybe gene mutation. These children susceptible to the aganglionosis due to abnormal genes, whether red gene or endothelin family of gene. This gene mutation may cause whether early neuronal cell death or early maturation or differentiation of the neural crest cells. So the result of these four items will be aganglionosis, absence of the ganglion cells from the affected segment of the bowel. This aganglionosis could be the cause for the spasm or spastic segment that present in children with Hirschspurung disease. This is all not. There is also other abnormalities, like abnormal cholinergic innervation. We say that the cholinergic type of the nerve fiber is responsible for contraction by acting on the acetylcholine. So in aganglionic segment, there is marked increase in the cholinergic nerve fiber. And this proposed to be the cause of the spasticity of this aganglionic segment, since the acetylcholine is the main excitatory neurotransmitter. This is number one. Maybe on the other hand, adrenergic abnormalities. We say that the nitric oxide is act to relax the bowel. So there is maybe abnormalities. There is maybe abnormalities in this part of the adrenergic innervation. However, we say that it's inhibitory, so it could not explain the presence of increased tone in the aganglionic segment of the bowel. The third item is nitric oxide abnormalities, evidenced by there is impaired nitric oxide synthesis in the aganglionic bowel with defective distribution of what is called nitric oxide synthase enzyme, which is responsible for the synthesis and the formation of nitric oxide. Nitric oxide is an important neurotransmitter involved in the relaxation of the smooth muscle. So this absence of disturbance could be attributed to the lack of the peristalsis, the presence of the contracted or spastic segment. Also, interstitial cells of Kagel. The distribution is abnormal in aganglionic segment. The gap junction may be absent or highly reduced, and all these proposed to be the cause for the presence of the spastic or contracted segment. Also, for some cases of persistent dysmotility after surgery for Hirschspurung disease, may be attributed to these abnormal interstitial cells of Kagel. The smooth muscle, and it is effectors, final effectors for the actions of the relaxation and the contraction, could be abnormal in Hirschspurung disease. The smooth muscle cytoskeleton either absent or weak in the aganglionic bowel. Also what's called neural cell adhesion molecule, cell-to-cell adhesion, either lacking or abnormal. So abnormalities in the smooth muscle could explain lack of peristalsis, presence of the tonically contracted segment in the aganglionic segment of Hirschspurung disease. Also abnormal proximal ganglionic segment. All of us know that the abnormality is localized to the aganglionic segment. However, recent research showed that no, there is maybe abnormalities in the proximal dilated segment. On the top of these abnormalities is what is called intestinal neuronal dysplasia. About 25 to 35 of Hirschspurung patients have associated intestinal neuronal dysplasia and could be cause of the persistent obstruction, failure of surgery for Hirschspurung, persistent dysmotility. So this intestinal neuronal dysplasia is identified pathologically and histologically by the presence of giant ganglia and ectopic ganglion cells. Could be associated or isolated phenomena in the proximal dilated segment of the Hirschspurung disease. The abnormal motility. Yes, there is abnormal motility in the affected segment or aganglionic segment, evidenced by stimulation. So in the dilated ganglionic bowel, the proximal bowel, the single stimulation induces rapid response in majority of the cells. However, in the transitional zone, we mean by the transitional zone, transition between the ganglionic and the aganglionic bowel. Repeated stimulation are needed to induce a response. Also in the aganglionic segment, there is response in only 20% of the cells. So this defect in the response could explain the presence of a functional intestinal obstruction. This is regarding the pathophysiology, which is very important in Hirschspurung disease to understand. That the definition is the absence of the ganglion cells, and the pathophysiology is the presence of the spastic or spasm with lack of peristalsis, functional intestinal obstruction. All this theory trying to explain this pathophysiological picture which is present in all children with Hirschspurung disease. What is the presentation? How is a child present? Maybe prenatal diagnosis or presentation, yes. However, it's very rare, usually due to total colonic affection, and the ultrasound will be fetal intestinal obstruction. The most common is the neonatal presentation. However, some children show delayed presentation later on. The neonatal presentation, most cases diagnosed in the neonatal period with a failure or delay to pass meconium beyond 24 to 48 hours. Number 2, distended abdomen, which is very characteristic. Number 3, bilious aspirate or vomiting with feeding intolerance. This is a non-specific or common presentation. However, there is maybe on the other hand, child or neonate presented with diarrhea due to Hirschspurung associated enterocolitis, which is a confusing presentation, as most children with Hirschspurung present with constipation. So this child may present with enterocolitis due to infections by the organism present in the gastrointestinal tract from this obstruction or functional spasm. This Hirschspurung associated enterocolitis may progress to what is called life-threatening toxic megacolon, sudden characterized by sudden marked abdominal distension, bilious vomiting and fever, dehydration and sepsis, may be shock. And on BR examinations, there is explosive evacuation of gas and full smelling stool. The pediatric surgeon must be aware for this serious and maybe fatal presentation or complication of Hirschspurung disease. On the other hand, childhood presentation in some children, the presentation may be delayed, and in such cases, presentation will be related to chronic constipation. Usually, the onset of constipation is around the time when the solid foods are initiated. Almost most children present after the neonatal have a short segment disease. However, there is maybe also some cases with long segment or even total colonic showing delayed presentation. How to diagnose Hirschspurung disease? Number 1, by the clinical presentation, as we said. Number 2, by the abdominal radiograph, plain X-ray and the contrast study. Number 3, anorectal manometry, which is an important tool useful to assess in the diagnosis of Hirschspurung disease. And number 4, rectal biopsy, which is a cornerstone for histological diagnosis. The plain radiograph will show the pictures of obstruction, whether distal colonic obstruction or distal ileal, depending on whether there is a rectosigmoid or total colonic affection. Sometimes pneumoperitoneum from perforation, which is equal about 3% of the patient. The water-soluble contrast enema is very important to show the constricted segment and the transitional zone and the transmission toward the dilated segment. However, this finding may be absent in about 10% of the neonates with Hirschspurung disease. Maybe no obvious transitional zone, no obvious caliber change in about 10% of the children with Hirschspurung disease. The water-soluble contrast preferred rather than the barium, as the enema may be also the definitive treatment for other conditions which make the differential diagnosis with Hirschspurung disease, like meconium ileus and meconium plaque syndrome. So we prefer to use water-soluble contrast for both diagnostic and therapeutic in some circumstances. The anorectal manometry. Anorectal manometry is very important and can be helpful in the diagnosis of Hirschspurung disease. It depends on the idea that the children with Hirschspurung disease lack the rectoanal inhibitory reflex. We says that when we distend the rectum with a balloon or with a stool, there is a reflex relaxation of the internal anal sphincter. In Hirschspurung disease, this reflex is lost, and with distension of the rectum, there is also contraction of the internal anal sphincter, which is very important. If this reflex is normal in normal children, this rule out Hirschspurung. However, if the reflex is absent, it should be followed by rectal biopsy, which is very important. Regarding rectal biopsy, it's very essential to confirm the diagnosis. The rectal biopsy developed into multiple stages. In the neonate, rectal biopsy usually mucosal biopsy done on the bedside, which is very important tool for the pediatric surgeon to be well trained to take a rectal mucosal biopsy. Rectal mucosal biopsy will show absence of the ganglion cells. Yes, no ganglion cells in the submucosal and the myenteric plexus. Both plexus devoid of the ganglion. However, take care that there is a normal zone of hypoganglionosis above the dentate line, 0.5 to 1 centimeter above the dentate line. So biopsy should be taken more than 1.5 centimeters. Actually, this will depend on the age of the baby or the neonate of the child. However, on the other hand, if you decide to take a too proximal biopsy, you may miss short segment of aganglionosis. So you need to stick to the rule. Number two, the presence of hypertrophied nerve trunk, which is very important to plus the absence of the ganglia to suspect the diagnosis of Hirschspurung. The third item, which is very important item, is the histochemistry staining. Histochemistry using acetylcholinesterase, which increased in the aganglionic segment, or positive staining for acetylcholinesterase enzyme. Very important. So combination of three: the absence of the ganglia, the hypertrophic nerve bundle, and the positive acetylcholinesterase staining. The fourth items may be useful for the rectal biopsy is the full thickness rectal biopsy and the staining with immunohistochemistry, and it is specific for the differential diagnosis of the Hirschspurung and its variant disease, and we will describe it soon. Now, what is the pre-operative preparation? Child suspected and diagnosed as a Hirschspurung disease. We need to perform pre-operative preparation, like any surgery, intravenous fluids, nasogastric drainage and rectal irrigations. The child with cardiac or congenital hyperventilation may need thorough evaluation or ICU admission. Extremely dilated colon. The surgery cannot be done and the anastomosis cannot be performed on extremely dilated colon. So surgery may need to be delayed until the caliber decrease, which may take weeks or months, or initial colostomy may be needed until the caliber reaches the normal to allow for safe anastomosis and avoid complication. The surgery performed on semi-elective surgery. The child prepared and introduced or subjected to surgery. The child can be discharged at home, yes, and the parent must be educated about the proper rectal irrigations. This is number one. Number two, educated about the Hirschspurung associated enterocolitis. During this waiting period, it may be serious problem. During the waiting period, And if any symptoms develop, the parent is instructed to come to the hospital very early. What is the basic surgical principles? It makes sense that we have an aganglionic part. We need to resect this aganglionic part and anastomose the ganglionic part above with the anus below. This is the idea for the surgery, with different operation described by different authors like Suavi, Swenson, Duhamel, or transanal or laparoscopic procedure. However, the question will rise now. What is the best operation for a child with Hirschspurung disease? And the answer will be surprising. The best operation is the one that the pediatric surgeon trained to do and does it frequently. This is the best surgery. So no universal best surgery for all pediatric surgeons. No, you will detect your best operations by multiplicity, by your performance as a surgeon, which is very important. Choose the surgery that you will train to do, and you will do it frequently and know the complication and how to deal with it. We will go rapidly through some principles of the surgical procedures, what's called Swenson procedure. Swenson use and remove the eganglionic colon and perform end-to-end anastomosis, full thickness. Cut and anastomose, remove the eganglionic and perform end-to-end full thickness anastomosis. However, in the procedure, the dissection must be very close to the rectal wall to avoid injury to the deep pelvic vessels or nerves or vagina or prostate or vas deferens or seminal vesicles. The long-term functional result reported to be excellent using this technique. To avoid the injury to the associated pelvic structures by performing full thickness dissection, Suavi procedure described. To perform the dissection submucosal, leaving outer aganglionic muscular layer and dissect from inside. So leaving part of the aganglionic segment, which is the outer muscular layer. This aganglionic segment claimed by some authors to produce long-term constipation due to incomplete excisions of the aganglionic rectum. However, the long-term follow-up showed that the results are similar to Swenson procedure. In the Duhamel, the idea is different. Duhamel pull the normal colon posterior to the aganglionic rectum and then firing both walls together, forming single wall or single chamber. This wall or this chamber is aganglionic anteriorly, as the authors leave the aganglionic anterior wall of the aganglionic wall, and then normally innervated posterior. So in the Duhamel procedure, you have two parts. Anterior wall of the single chamber is aganglionic, and the posterior wall is normally innervated. This reservoir or the presence of this aganglionic wall may later dilate and form what's called Duhamel pouch. This pouch may filled with stool and obstruct the bowel through, causing obstruction to the gastrointestinal tract. It is an easy, yes, no submucosal dissections. It is a safe, long anastomosis reduce the risk of the strictures. There is a long-term results in many reports similar to other surgeries or maybe inferior to transanal as described by some authors. The laparoscopic pull-through. The idea of the laparoscopic pull-through is to perform a laparoscopic biopsy to locate the transitional zone. We need to know where the ganglia end in this point or that point, and then we perform laparoscopic mobilization of the rectum, and with from below short mucosal dissection through the perineal approach, and the rectum prolapsed through the anus, and the anastomosis performed from below. The transanal is a completely perineal approach. Same principles as the laparoscopic approach, however, without laparoscopic mobilization. The submucosal dissection is continued for several centimeters, and then the dissection is continued until the full thickness of the rectal wall, dividing the vessels from below as they enter the rectum. This transanal procedure is an easy, less complications. However, it is limited by the length you can pull from down. So in a long segment disease, you cannot pull the whole colon transanal due to attachment of the splenic flexure, due to the fixation. So you need to perform this surgery assisted, whether with laparoscopic assisted or open assisted, to make a small umbilical incision or enter by laparoscopy to release the adhesions at the colonic flexure. The entire rectum and the part of the sigmoid, yes, can be delivered through the anus, and the transitional zone identified anastomosis is done from below. Some surgeons don't perform submucosal dissection and perform transanal Swenson, perform full thickness, end-to-end anastomosis. So transanal, maybe transanal Suavi, maybe transanal Swenson. As we say that if the proximal transitional zone above the proximal sigmoid, it needs laparoscopy or a small umbilical incision. It is an assisted surgery to allow adequate length of the ganglionic colon without tension on the colon to avoid retraction, post-operative, or ischemia, or many complications. There is an important point here is a histological transitional zone. What's histological transitional zone? Is a point identified by the histology that the ganglia is absent and the ganglia is present, the junction between these points. And there is a transitional zone on the contrast enema. As we said at the start of the lecture, that there is maybe contrast water-soluble enema showing a transitional zone. However, the two zones may be different. So we may have transitional zone on the contrast study with proximal histological transitional zone. If you depend on the contrast study only, you will pull, or you may pull transitional zone or aganglionic part and perform the anastomosis with area which is hypoganglionic or aganglionic, and the child not doing well after the surgery. So please perform histological frozen section examination before you decide the point that you will anastomose with it. Histological transitional zone is very important and should be defined prior to anal dissection, as it may be more proximal to the transitional zone in the contrast study. What is the post-operative management? You suspect the disease, diagnose the baby, and perform surgery, whatever the time. What is your post-operative management? Number one, most children can fit and discharge it within 24 to 48 hours, depending on the type of the procedure. Number two, the anastomosis is need to be calibrated with appropriate size dilator or finger, 1 to 2 weeks daily or weekly calibration by the surgeon. The parent must be educated to protect the buttocks with a barrier cream to avoid perennial excoriations and breakdown. The signs of the symptoms of post-operative enterocolitis, it's very important to avoid fatal sequelae of the enterocolitis, which can happen even if there is no history in the pre-operative period for enterocolitis. So the enterocolitis may appear at the first presentation post-operative. How to manage? There are some challenges for management. Number one, Hirschspurung in a small infant. Whether to perform single stage or one stage, pull through, or whether to perform stoma, then pull through. Many reports suggest that the one stage was safe and avoid the morbidity of the stoma and more cost effective. However, it must be very clear that stoma is still mandatory in severe enterocolitis, in the presence of the perforation, in the malnutrition, massively dilated proximal bowel, if not possible, to reliably identify the transitional zone of the frozen section. So in this situation, stoma is mandatory. If you perform single stage, you will have more and more complications and your procedure may fail. Number two, regarding short segment Hirschspurung disease, some pediatric surgeons suggest non-operative management using enemas, laxative, or performing simple myectomy to treat this small area of obstruction. However, these approaches, enemas, laxative, or simple myectomy, don't provide good quality of life for most infants, and most pediatric surgeons recommend pull through even for a short segment disease, even for a short segment to have a good quality of life. Regarding what's called long segment Hirschspurung disease. What is long segment? It is defined if the transitional zone found proximal to the mid-transverse colon. Proximal to the mid-transverse colon called long segment disease, affecting about 5 to 10% of all children. These patients tend to present at earlier age, yes, has equal male to female incidence, and has a higher risk for enterocolitis both before and after surgical repair. The long segment may be total colonic, affecting the whole colon, extensive aganglionosis, extend to the part of the small intestine, or near total, most of the small bowel is aganglionic as well. Regarding total colonic aganglionosis, means no ganglia in the whole colon. Some cases of this disease or this type don't show neonatal obstructive symptoms and pass the neonatal period unnoticed, with milder symptoms appear later in life during childhood. The presentation may be delayed until weaning in some cases from the breast milk. This may be difficult to diagnose, this total colonic aganglionosis. Also, the radiological and the histological characteristic of the total colonic may be differ from the short segment aganglionosis. The contrast enema show with shortened, relatively narrow colon, which is called question mark, like the question mark, and the typical caliber change seen in cases of Hirschspurung disease may be absent or not seen in a patient with total colonic aganglionosis. The rectal biopsy in total colonic aganglionosis will show the absence of the ganglia, with or without hypertrophied nerve may not be present, and or abnormalities of the acetylcholine staining also may or may not present. The initial approach to diagnose that this child or this baby diagnosed with total colonic aganglionosis is to perform sequential colonic biopsies, multiple colonic biopsies. However, avoid to take the appendix for initial biopsy, as this may result in false positive diagnosis due to normal rarity of the ganglion cells in the appendix in a children with shorter segment disease. So if you decide to take a biopsy, you can biopsy the cecum, preferable than the appendix, to diagnose the presence of the total colonic disease. How to manage? How to manage a child or neonate with total colonic aganglionosis. Most pediatric surgeons, it seems, sense that they perform a stoma once the level of aganglionosis identified intraoperative by the frozen section, and then wait for the result of the permanent and perform the definitive procedure later. Is it possible to perform single stage to remove all the colon at one session and perform anastomosis between the small bowel and the anus? It's a controversial issue. The primary pull-through without stoma. Number one, it requires high degree of confidence. You are very confident in the pathologist that the frozen section is well accurate, no ganglion cells in the whole colon, so you decide to remove the whole colon based on a frozen section alone, which is not accepted. Number two, there is a report of skip areas in the total colonic, and the permanent section is mandatory. Number three, some pediatric surgeon believes that the outcome following the pull-through are better once the stool has thickened, and this usually happened after 6 months or so. So for these three reasons, the primary pull-through is not recommended by the most of pediatric surgeons. The type of the operation for the long segment, how to manage, may be what's called the straight pull-through. Using one of the standard technique, you can perform Suavi, Duhamel, or Swenson, or what's called colon batch. What's colon batch? You leave part of the aganglionic colon in a case of the long segment disease and batch the small bowel with this long segment, anastomose part of the colon to the small intestine, whether using the left side of the colon called Martin or the right side of the colon, Comora. What are the value? There will be two benefits. Number one, there will be decreased stool frequency. To decrease stool frequency due to presence of the colon and the part is aganglionic, there will be some sort of decreased stool frequency, and to increase the water absorption. Also, these 2 points may be advantage. However, This aganglionic colon may make some problems, may become dilated or may become infected, and you need to remove the patch and perform stoma. Ileoanal anastomosis with pouch, to perform anastomosis between the ileum and the anus and perform pouch, different shapes of pouch for reservoir. The straight ball throw, children in this technique tend to experience gradually decreasing stool frequency over time with acceptable quality of life. And most pediatric surgeons refer to perform the short Duhamel procedure, provide reservoir and avoid and associated with acceptable complication. So this is the first line of management of long segment or total colonic. Number 2, colon batch procedure. Result in, as we said, decreased stool output, better water absorption. However, the presence of this aganglionic bowel tend to dilate, and many patients may develop severe enterocolitis that require removal of the patch or permanent stool. As we said in these pictures, this is the colon batch using the left colon called Martin procedure. Cutting, removing this part of the colon and then separating the small bowel, making long side-to-side anastomosis between the colon and the ileum. This will form one pouch or one tube, which is part of it ganglionic and part aganglionic. The small bowel is ganglionic and this patch of the colon is aganglionic. Long anastomosis may be susceptible to anastomotic leakage or kinking, also may be ulcers or anemia formation. On the other hand, using the right colon Komura operation to cut and perform, take the right colon to anastomose also to the ileum. However, it performed at first with a stoma. Then you can pull through this segment as it is to anastomose to the anus. It's a complicated surgical technique and staged procedure having the same drawbacks of that this aganglionic patch may become dilated. There is maybe high risk of the enterocolitis leading to reversal of the surgery and stoma again. The ileoanal anastomosis means that we anastomose the ileum to the anus. However, to decrease the frequency of the stool and the diarrhea, we perform a pouch. Pouch means like containers to accommodate for the stool, maybe S-shaped or J or W pouch. However, this pouch susceptible to inflammation and the form what's called pouchitis. Internal anal sphincterotomy may be helpful to prevent the obstructions and enteritis. This is called ileoanal anastomosis, one of the options of the treatment of long segment disease, total colonic disease, to remove whole colon and bring the ileum to the anus direction. Covering ileostomy, it's very important that some pediatric surgeons recommend covering ileostomy during the operative anastomosis to prevent the post-operative severe perineal excoriation until the patient completely toilet trained. It's controversial. Some pediatric surgeons don't agree as intimate perineal care can prevent severe perineal excoriation. So with ileoanal anastomosis, some pediatric surgeons perform covering ileostomy and others don't perform or don't agree, as they suppose that the intimate perineal care can prevent the expected or suspected severe perineal excoriation. On the other hand, we may be very rarely near total intestinal ganglionosis. The whole entire gastrointestinal tract is aganglionic, leaving about 10 to 40 cm of the normally innervated jejunum. So the management in such cases will focus on the intestinal failure. The child may require TBN from birth, central venous catheter insertion, and gastrostomy for continuous feeding. The prevention of the sepsis and the bacterial outgrowth in these children is very important. At the exploration, the goal is to determine what are the extent of the aganglionosis based on the frozen section. This is number one. Number two, to create a stoma, whether at the most distal point of normally innervated bowel or more distally with a ganglionic bowel. This is very important. Near total, it's extremely rare condition diagnosed intraoperative with frozen section. The subsequent management will depend on the length of the normally innervated bowel, which is still present, and the child clinical status. If there is significant dilatation in the proximal innervated bowel, this intestine or this part of the intestine can be used for lengthening procedure. like transverse enteroplasty procedure. The management in such children focused on the prevention of intestinal failure. You need large intestinal capacity to avoid intestinal failure. There is a surgery operation described by Ziegler called myotomy procedures, involve the myectomy and myotomy of the length of the aganglionic small bowel distal to the transitional zone to increase the absorptive capacity. For some patients, the small bowel or combined small bowel and liver transplantation may offer the only chance for survival without total parenteral nutrition. So this is how to manage Hirschsprung in a small neonate, short segment, long segment disease of Hirschsprung. Now, what about the child not doing well after Hirschsprung disease surgery? We mean by not doing well that the child is still obstructed, child developed enterocolitis, child developed fecal soiling, a child developed the same constipation as preoperative presentation. So when you face a child not doing well after surgery for Hirschsprung disease, suspect. Number one, post-operative complication, whether early complications or late. Number two, that your diagnosis is wrong. There is a problem with what's called variant Hirschsprung disease or pseudo Hirschsprung or allied disorder with Hirschsprung disease. Number one, the early and late complications related to surgery for Hirschsprung may be obstruction, stricture, twist, or duodenal pouch dilatation and obstruction, SWABI cuff, long muscular cuff. As we say in the SWABI, we leave the anterior aganglionic muscle, or maybe anastomotic leak or abscess. The late complication may be mechanical obstruction, pathological problem related to the residual aganglionosis, or you pull the transitional zone, or maybe some other causes. The early complications, you can know them like any surgery: general complications, bleeding, infection, injury, risk of anesthesia, stoma-specific complication. If you perform a stoma, it may be stricture, retractions, prolapse, or skin breakdown, and anastomotic complications. The anastomotic leak colostomy may be considered in such cases if there is a stricture or lector muscular cuff related to narrowing managed by repeated dilatation. If not successful, you may need to perform redo surgery. For a twist, immediate surgical redo is necessary if there is twisting of the anastomosis. The most important one is the long-term post-operative complication. After surgery for Hirschsprung disease, the late complication include: number one, persistent obstructive symptoms; number two, fecal soiling; number three, enterocolitis. It is very important for the pediatric surgeon to follow children with Hirschsprung disease very well post-operative to identify and timely treat this problem. What is meant by the persistent obstructive symptoms? Means that the same obstruction is still present after surgery. Child came to you with constipation and post-operatively constipated. The child may pass into a period of improvement or may not. Continuous constipation. The fecal soiling means that the child transferred from being constipated to being incontinent, which is more serious problem, and the enterocolitis. The persistent obstructive symptoms may present with abdominal distension, bloating, vomiting, ongoing severe constipation. In some cases, the child may have good response to the surgery at first, then experience obstructive symptoms, or in other cases, the child may not have any improvement in the post-operative period. What are the causes for these obstructions? Maybe mechanical obstruction related to your work, maybe recurrent or acquired aganglionosis, maybe motility disorder in the residual colon or the small bowel, or maybe internal sphincter achalasia or functional megacolon. So we may have 5 causes to explain, or 5 reasons for the obstructive symptoms. Number one, the mechanical obstruction may be related to stricture, common after SWABI or Swenson, may be related to the retained pouch of the duodenal the aganglionic bowel may fill with the stool and obstruct the bowel-through segment, may be related to twist. The bowel segment has an anterior posterior wall. You anastomose the anterior point to the posterior point and making it twist, may be related to narrowing by the long muscular cuff after Suavi operation. So this is the causes of what? Of mechanical obstruction. So the diagnosis will be easy on direct rectal examination and the contrast study. As we see, this is obstruction, complete obstruction, and suppurations after Suavi. This is duodenal pouch, dilated and obstructing the bowel-through segment. And this is image by the contrast study showing the twist of the segment, which is very important for early identification and treatment. How to manage an stomatic structure? At first, repeated dilatation. If intractable, we can try it antegrade dilatation, or in some cases, the redo may be necessary. This is number one. Number two, in the dilated pouch of the duodenal must be resected, whether from above or extending the stable line from below to remove this dilated pouch. Twisted bowel-through need redo surgery. The narrow muscular cuff after Suavi operations occasionally divided laparoscopically or may need to dilatations or redo. This is the first cause for the persistent obstructive symptoms in the mechanical causes, including the 5 causes. The persistence or acquired aganglionosis or transitional zone bowel-through, the causes is residual aganglionosis or transitional zone, usually from error in the pathology. The pathologist didn't determine exactly the site of the ganglion cells. So you anastomose area which is hypoganglionic or aganglionic, or you don't depend on a frozen section and you perform anastomosis depending on the contrast, enema or your necktie. So the result will be anastomosis with transitional zone or residual aganglionosis. So there is other condition called acquired aganglionosis, which may result from neuronal cell death after ischemic insult on the distal bowel-through, or may be related to some change in the natural body growth, causing upward tension on the bowel-through segment. The diagnosis is to perform a biopsy, looking for the presence and the number of the ganglion cells, and some surgeon believes that the measurement of the nerve trunk is useful marker for transitional zone bowel-through, although this remains controversial. The specimen of the original surgery you perform must be reviewed and the further section should be taken circumferentially at the resection margin, since the transitional zone can be asymmetrical in children with Hirschspurung disease. What does this mean? This means that the presence of the aganglionosis may not take the same level all around. So on the mesenteric side, the ganglia may be present below the anti-mesenteric side. So the transitional zone may be asymmetrical, not at the same level. The ganglia not present at the same level all over the circumference of the transitional zone. So this may make that you see ganglia on the mesenteric side, and then there is no ganglia on the anti-mesenteric side, or the reverse. So please confirm that you take the biopsy from both mesenteric and the anti-mesenteric, confirm that the ganglia is present before anastomosis. How to manage? The best management for the persistent or acquired aganglionosis is repeat bowel-through using either Suavi or Swenson or duodenal procedure. The third item is the motility disorder. Motility disorder is a cause for the persistent obstructions or failure of improvement after bowel-through for Hirschspurung, yes, which may be focal, involving the left colon, or generalized, may be isolated motility disorder or associated with intestinal neuronal dysplasia. The diagnosis will depend on the colonic transit study and the manometry, maybe laparoscopic biopsy, looking for the evidence of the intestinal neuronal dysplasia. How to manage? If the abnormality is focal, you can manage with resection and repeat the bowel-through. If there is diffuse dysmotility, the bowel management will be managed with antegrade enema and through the cecostomy tube, or sometimes we perform malone using the appendix attaching the appendix to the abdominal wall and making enema through the appendix is called the Malone appendicoscopy. So this is the management of the motility disorder if this is the cause for the obstruction, post Hirschspurung disease surgery. There is a condition called internal sphincter achalasia. Internal sphincter achalasia refer to the non-relaxation of the internal anal sphincter. We says at the start that there is a reflex called Rictoanal inhibitory reflex. When rectum distend, the internal anal sphincter relax. In the children of Hirschspurung disease, this reflex is lost. So some children developed obstructive symptoms post Hirschspurung disease due to spasm or achalasia or failure of relaxation of the internal anal sphincter. So please suspect this caused by the clinical improvement to the injection of botulinum toxin. Most of the children get free of this problem by the age of the 5 years, diagnosed by the clinical response to intrasphincteric botulinum toxins. So internal sphincter achalasia may form a problem in the post-operative period of the children with Hirschspurung disease. How to manage? It seems sense that we need to perform internal sphincterotomy or myectomy to obligate this sphincter to relax. However, because this problem is self-limiting, some pediatric surgeons prefer to use chemical sphincterotomy and inject botulinum toxins or nitroglycerin paste to be reversible. So relaxation in such cases not permanent, destroying the sphincter and may lead to incontinence later on. They manipulate the case with the using of the intrasphincteric botulinum toxin or nitroglycerin paste. The last cause for the persistent obstructive symptoms is functional megacolon. So the child with obstructive symptoms may have functional megacolon. This functional megacolon group of children don't have identifiable cause of the symptoms and don't respond to the surgical or chemical relaxation of the internal anal sphincter. Most of these children have a stool holding behavior, and most of these children with Hirschspurung because of their predisposition to constipation. So persistent obstructive symptoms may be related to mechanical cause. Your work is not well, stricture, long muscular cuff, and twist or narrowing of the cuff or duodenal pouch dilatation. All of this is the mechanical causes for the obstruction, or maybe related to the pathological errors, residual ganglionitis or some form of zonal or transitional zone pull-through, may be related to motility disorder, may be related to internal sphincter achalasia, and lastly, may be related to what's called stool holding behavior, as the children with Hirschspurung disease have a predisposition to constipation, so they continue constipating in the post-operative period. These children treated with a bowel management regimen, and in some cases, antegrade enema or proximal stoma may be. So the question now, what's the indications for the redo surgery in obstructive symptoms? Number one, anatomical problems, yes. Structure, twist, retained dilated segment, obstructive duodenal. Number two, pathological problem like residual ganglionitis or transitional zone and other causes like Hirschspurung associated enterocolitis, and take care that sometimes the child may have a combination of the problem. Redo surgery from the start means that if you see a child with obstructive symptoms, you will take the child to the OR. Is there a time interval important? Yes. There is classifications into 3 groups. Immediate redo within the first 6 months after the primary pull-through or even earlier. Gross anatomical problem like twist structures obstructing duodenal pouch, you cannot wait. You may need immediate redo also. Or misread of the frozen section. Sometimes pediatric surgeon informed that the frozen is misread when doing the permanent section. In such case, immediate redo is recommended because of the possibility of the fewer adhesion. Then we may have early redo and late redo, sometimes in some cases of residual ganglionitis and the transitional zone also. What are the causes for this waiting? Some authors reported that the conservative surgery or conservative management, it may be obligatory in all cases except the torsion for about 1 year. If this is unsuccessful, the redo surgery would be considered. The reason for waiting that any additional scar fibrosis tend to subside, which may be the cause of the initial obstructive symptoms. However, this is still controversial, and the decision on the time to operate is an individual case, depend on your child, clinical presentation, the previous surgery, the suspecting pathology, so maybe immediate reconstruction is recommended in some cases, and conservative may be indicated in other cases. What is the best procedure for redo? Actually, or surprisingly, the procedure choice is far from being easy or obvious. No consensus and no best operative approach for redo. The redo will depend on the presentation of the child, the type of the procedure depend on the type of the complication presented, the underlying pathology, the previous procedure, the rectal blood supply, fibrosis, the presence of inflammation of the pelvis or the perirectum. It's not an easy job. For example, in the redo SWAVI, if the child were subjected to SWAVI at the first surgery, the mycosectomy or redo mycosectomy sometimes it may be difficult, and the third dissection may be needed at the level of the previous anastomosis, which seems to be hazardous. So if unable to access this submucosal plane, conversion to Duhamel is recommended by most pediatric surgeons as a possibility for redos for the SWAVI. The transanal approach is generally preferred with a long segment. If you operate on a long segment, the redo will be on the transabdominal or twisted ball through the structures due to ischemia or leak, preferably revert with a transabdominal. Also, protective colostomy or ileostomy, many reports describe that they are necessary to prevent the recurrent fistula after redo. The posterior sagittal approach with laparotomy is useful alternative described in patients with frozen pelvis structure, fistula, or located at site not easily accessible. Allow good exposure and dissection under direct vision and described by some authors. So this diagram illustrates the summary of the story of the obstructive symptoms following post-surgery. If you have a child with obstruction, please perform rectal examination and contrast treatment. If there is mechanical causes, structure, twist, narrowing, try dilatation, then immediate redo. If there is no hope of the dilatation. If there is no mechanical obstruction, no structure, no twist, no narrowing, take a rectal biopsy. If the rectal biopsy showing aganglionosis or transitional zone pulse through, redo is indicated. If no pathology in the rectal biopsy, normal ganglionic, then botulinum toxin injection. If there is clinical improvement, repeat as you need. If there is no clinical improvement, the motility study is indicated. If showing normal or generalized abnormalities, bowel management, if focal abnormality is detected, colonic resection. So this scheme put the obstructive symptoms on your table. If there is mechanical or non-mechanical obstruction, it's an easy to follow this scheme to solve the problem of the mechanical obstruction following all through. Mechanical means that the child is still obstructed, that there is no improvement in the previous problem. On the other hand, we may face with fecal soiling. Fecal soiling, after the Hirschspurung disease, the fecal soiling should not occur as the child is born with normal anal canal and normal sphincter. The physiological mechanism for the continence are the normal sensation, voluntary control, appropriate colonic motility. The fecal soiling may be more distressful to the family of the child than constipation or obstructive symptoms. What are the major causes of the soiling? Maybe true incontinence. You destroy the sphincter or destroy the sensation, which is very important. Or maybe pseudo incontinence related to what's called overflow incontinence due to constipation and loss of the rectocolonic inhibitory reflex. The true incontinence, most serious problem that significantly reduce the quality of the life of the child in comparison with the obstructive symptoms, and the differentiation between the pseudo and the true incontinence is very important. The causes of the true incontinence may be abnormal sphincteric function, sphincteric injury during the pull-through, overstretching of the anus during transanal pull-through, or oversplitting during myectomy or sphincterotomy, usually diagnosed using anorectal manometry or endorectal ultrasound. Or abnormal sensation. We have two types of abnormal sensation: the lack of the sensation of the full rectum, which identified using anorectal manometry, and inability to differentiate between the gas and the stool due to distractions of the or loss of the transitional epithelium because the anastomosis performed below the dentate line. Destruction of this area will destroy the receptor and makes the child unable to differentiate between whether the coming is gas or stool, and leading to fecal soiling. On the other hand, the pseudo incontinence, if the sphincteric function and sensation are well and not affected, there is maybe pseudo incontinence from constipation with overflow of liquid stool, or there is maybe additional problem due to loss of the normal rictocolonic inhibitory reflex. Normally, the presence of the native rectum inhibits the colon to stop contractions. In some children, there is maybe excessive motor activity in the proximal colon combined with loss of the native rectum leads to loss of the rictocolonic inhibitory reflex, and this will lead to pseudo incontinence. So the normal sphincter cannot overcome this excessive contraction, and there is soiling of the stool. Pseudo incontinence may be classified into severe obstipation or severe constipation, massively distended rectum with overflow of the liquid stool, or may be related to something called hyperperistalsis of the pulled-through bowel. Hyperperistalsis. This pulled-through is hyperperistaltic, contracting more colonic irritation and more colonic contraction due to absence of the native rectum, so that the anal sphincter cannot achieve control despite the presence of the normal function and sensation. The difference will be obvious on the contrast study. If we encounter dilated, hugely dilated colon, this is called the severe constipation or hypomotile colon. If we find that there is a contracted or normal or even narrow caliper pull-through colon, this is hypermotile or hyperperistalsis. How to manage soiling? Very important that the management will depend on the clear understanding for the cause. You deal with a true incontinence or pseudo incontinence. True incontinence means distractions of the sphincteric functions of the sensation. It will be very obvious during the careful examination and anus examination. Examine the anal canal for the dentate line. Is there a dentate line or not? Is there epithelium present, dentate line present, or the anastomosis performed very low and the anus is patulous and open? In such a case, you can diagnose that the cause of the incontinence is a true distractions of the anal canal and the dentate line. So the careful examination is very important. So the differentiation will be evident like this, very patulous and open at all in anus. And this is also, there is loss of the dentate line, no dentate line here due to surgery destroying the anal canal, which is a catastrophic event on a child with normal sensation and normal anal canal in Hirschspurung disease. The investigation will show dilated hypomotile colon or the hyperperistalsis or hypermotile colon using the contrast enema. Very important item. Neither sphincteric weakness nor the sensation is amenable to surgical treatment. No treatment available for the weakness or the abnormal sensation, although some recent authors described some repair of the sphincter. However, the result is still need more and more studies. The children with true incontinence managed using what's called power routine, constipating diet, stimulant, laxative, anti or retrograde enema, the biofeedback training, especially for weakness, and sometimes colostomy may be indicated in some cases. However, some also reported that these true incontinence and patulate anus cannot be treated with a bowel management, and the most children may need to perform daily large volume enema or Malone appendicostomy to wash the colon every morning and night to help these children to achieve acceptable quality of life. Children with pseudo incontinence managed according. Children with severe constipation, we mean dilated hypomotile colon, will be benefit from the stimulant laxative to stimulate this lazy colon to evacuate this content or stool. On the other side, children with hyperperistalsis or hypo or hypermotile colon, non-dilated hypomotile colon, will need to change the motility, such as using some medication as a bromide, change the consistency by the constipating diet if failed bowel management with a small volume enema. So the summary, to summarize how to deal with fecal soiling following pull through. At first, examine your child generally and the anal and rectal examinations, perform X-ray and contrast the enema. If sphincteric function and sensations abnormal, this is true incontinence. The treatment will be bowel routine, constipating diet, biofeedback, sphincteric, especially for sphincteric weakness, daily large volume enema, or sometimes colostomy. If the sphincteric function and sensation normal, in such case you deal with pseudo incontinent by the X-ray and the contrast enema. Dilated hypomotile colon filled with stool, give stimulant laxative if inadequate in achieving rectal emptying, retrograde or antegrade enema. If non-dilated hypermotile colon, the colon caliber is not dilated, give the child flowing the colon down by the lopramide and also give constipating diet and if filled enema. So this diagram is very important to deal with fecal soiling following pull through. Please don't destroy the anal canal and the dentate line. Please perform the anastomosis at the proper site. No, neither the sphincteric loss of the sphincteric function nor the sensation are amenable to treatment. No treatment for such conditions. Sometimes some authors claim that with bowel management, some children improved with true incontinence. However, this result needs to be widely validated before acceptance. The enterocolitis is the third one. May be present before and after, especially for younger children. Long segment disease, trisomy 21. Its etiology is unknown. May be related to the stasis or alteration in the intestinal mucin or immunoglobulin. Clinically, they present with fever, distension, elevated leukocyte, evidence of intestinal edema. There is overlap between the enterocolitis and the gastroenteritis, so the true incidence is unknown. There is recently score of about 20 points developed, depending on the history and the physical examination and radiology. If the child take 10 or higher, it associated with positive diagnosis of enterocolitis by the expert, international expert of panel. This is the score, point in the history and point in the physical examination, and each point take 2 or 1 score point. This is also in the radiology, 1 point, and in the laboratory 1, the total of 20, and you can put your child on this score to determine the degree. The preventive measures, all of us know that the routine irrigation, the metronidazole is very important for high-risk group of the children, and the parent education is very essential to reduce the risk and return that for early return of the child if developed any symptoms. The treatment of enterocolitis mainly conservative, nasogastric drainage, intravenous fluids, and broad-spectrum antibiotics, decompressions of the rectum and the colon using rectal stimulation or irrigation. There is something called Hirschspurung associated inflammatory bowel disease. Yes, small group of the children with Hirschspurung may develop condition like Crohn's. This consists of chronic inflammation or maybe fistula, and the risk factors long segment and trisomy 21. This condition may be part of the Hirschspurung associated enterocolitis or may be separate entity. In many cases, the use of the biological and other anti-inflammatory medications that used to treat Crohn's are ineffective in treating this problem, and some of these children may require stoma. Regarding the quality of life in Hirschsprung disease children, despite the relatively common occurrence of these problems, obstruction, soiling, enterocolitis, most of the children resolve or get free from this problem at the 5 years of life. However, studies suggest that sexual function, social satisfactions appear to be relatively normal in most patients once they reach the late teens of their life. However, there are exceptions for this rule in children with long segment disease, trisomy 21, other abnormalities like congenital heart disease or mental retardation. This is very important, which is items for the child not doing well after Hirschsprung. May this child develop post-operative complications, obstructive symptoms, maybe fecal soiling, or maybe there is enterocolitis. The other group, which is very important, is a variant Hirschsprung disease or pseudo Hirschsprung disease. This variant means symptomatologically these diseases resemble the Hirschsprung. So this is disease group that present with clinical picture resemble Hirschsprung, delayed passage of the meconium, abdominal distension, severe chronic constipation in young child, despite the presence of the enteric ganglion cells, or may present on the other extreme to the pediatric surgeon as a neonatal ileus that require urgent surgery, as the case with intestinal atresia or Hirschsprung disease. So may present by the clinical presentation or may present on the OR, on the table with neonatal ileus that require urgent surgery. Resemble the Hirschsprung disease, cannot be differentiated from the Hirschsprung disease. Allied disorder Hirschsprung disease classified in 2 categories based on the histology by the hematoxin and eosine and acetylcholine strain staining. With abnormal ganglion cells, yes, there is abnormality in the ganglia, immaturity, hypoganglionosis, dysplasia, diffuse ganglioneuromatosis, or with normal ganglia. Disease similar to the Hirschsprung with normal ganglia, megacystitis microcolon, segmental dilatation, internal anal sphincter achalasia, chronic idiopathic intestinal pseudo obstruction. How to diagnose this allied disorder? Because you can diagnose it as a Hirschsprung disease. By the clinical presentation, it is difficult and challenging. The same clinical presentation like Hirschsprung disease in the neonate or young adult. Also by the neonatal ileus require urgent surgery. On the OR, you will find situation like Hirschsprung disease, aganglionic or contracted segment and dilatation, proximal dilatation. By the pathological diagnosis, rectal biopsy is a cornerstone for diagnosing these types of disorders. Rectal mucosal biopsy with acetylcholinesterase enzyme histochemistry and full thickness biopsy with immunohistochemistry, which is very important. Clinically resemble Hirschsprung disease. If you see a child with the disease presentation by variant of the Hirschsprung disease, the first items, as we said for the Hirschsprung, you perform rectal mucosal biopsy. The primary goal for rectal mucosal biopsy is to diagnose Hirschsprung and confirm or exclude absence of the ganglia, hypertrophied nerve ending present, and the acetylcholinesterase staining by the frozen section, and then confirm it with the permanent section. Number 2, full thickness biopsy. When there is a therapy-resistant constipation or functional bowel obstruction, despite the presence of the ganglion cells on the normal acetylcholinesterase activity in the rectal mucosal biopsy. In such case, the full thickness biopsy is indicated for the differential diagnosis, and the immunohistochemistry will be indicated for the differential diagnosis. Immunohistochemistry, this is some examples: BCL2, S114, CD56, and each one describes certain specific pathologies: the size of the ganglia, the interstitial cell of Kagel, the size and the density of the ganglion cells. So this is how to diagnose allied disorder for Hirschsprung disease. Number 1, take a rectal mucosal biopsy and stain with hematoxin and eosine. If there is absence of the ganglia and increased acetylcholine, this is Hirschspurung. If there is presence of the ganglia, normal acetylcholine, however, there is therapy-resistant constipation or functional obstruction, perform full thickness biopsy from 3 locations. These 3 locations is at the site of the calibrate change, the sigmoid, colon, and the terminal area. Perform 3 location and stain with immunohistochemistry to diagnose this intestinal disorder, ganglionomatosis, immaturity of the ganglia, isolated hypoganglionosis, absence of the argyrophil plexus, or segmental dilatation or pseudo obstruction. If the rectal mucosal biopsy stained with hematoxin and leucine and acetylcholine enzyme showing hyperganglionosis or giant ganglia, ectopic ganglia, this is intestinal neuronal dysplasia. If the ganglion cell is normal with normal activity, but there is absence of the rectoanal inhibitory reflex, this is intestinal sphincter Achilles, internal sphincter Achilles. Very important diagnostic algorithm for allied disorder of Hirschspurung. Perform rectal mucosal biopsy and then full thickness if indicated in a cases with normal result of the rectal mucosa and persistent or resistant to treatment constipation or functional intestinal obstruction. Neonatal ileus require urgent surgery. Pediatric surgeon called to the ER and there's a child with neonatal ileus you decide to operate on. Intraoperative full thickness biopsy is essential to differentiate the variant of Hirschspurung disease at the caliber site at the terminal ileum at the sigmoid. So during urgent surgery, this is the diagnosis. Urgent surgery, the finding will be caliber change or intestinal atresia, the same presentation like Hirschspurung disease. In such case, perform full thickness biopsy from the 3 locations, caliber change site, terminal ileum, and the sigmoid, and perform acetylcholine trace staining and immunohistochemistry. If there is ganglion cell small and sparse, this is congenital isolated hypoganglionosis. If there is ganglion cells small but not sparse, immaturity. If there is absence of the ganglion, hypertrophied nerve fiber, acetylcholine trace staining, this is Hirschspurung disease. So this is diagnostic algorithm how to diagnose the child with variant Hirschspurung disease subjected to neonatal ileus. So there is some types of the details of the disorders regarding the immaturity of the ganglion cells, extremely rare, decreased disease of the normal number, and extremely immature cells, usually extending from the jejunum to the rectum. At laboratory, the caliber change usually recognized and stoma usually required, and pathological diagnosis confirmed intraoperative full thickness biopsy. Congenital generalized hypoganglionosis. This is very difficult to differentiate from the Hirschspurung disease intraoperative, as there is collapse of the whole colon and dilatation of the small bowel, like the total colonic ganglionosis. Usually, jejunostomy stoma is required to be functioning well, as ileostomy may not be functioning well. This condition requires special attention in the management due to its rarity. So the pediatric surgeon finds that there is a collapse of the whole colon, dilatation of the small bowel, diagnose the case as total colonic ganglionosis, and perform ileostomy. This ileostomy will not be efficient to release the ileus, and the child need change to the jejunostomy, which will expose the child to many stomas, maybe with enteritis and loss of the gastrointestinal tract, and the only hope will be intestinal transplantation after that. This is also isolated hypoganglionosis, may be congenital and acquired disease, affecting the number of the ganglia decreased. However, in the congenital type, the size of the plexus is also small. In the acquired, the size of the plexus is normal. There is decreased number of the ganglia related to degeneration of the ganglia. Some authors claim that these may happen, acquired isolated hypoganglionosis, due to infection with parasite Trapezioma cruzi from chronic constipation or chronic gastroenterocolitis or peritonitis may lead to destruction and atrophy of the ganglia, and the treatment will be resection of the affected segment. However, in congenital type, this motility may persist and re-enterostomy may be needed. Also, intestinal neuronal dysplasia, which is described in the proximal segment of the dilated ganglionic segment, may be type A or type B, related to the diminished of the sympathetic innervations of the myenteric plexus, or may be related to the giant ganglia, increased acetylcholine staining. This intestinal neuronal dysplasia must be diagnosed and may be the cause for dysmotility or persistent obstruction post-Hirschspurung disease. This may be resolved on oneself, however, it may need the internal sphincter myotomy. The internal sphincteric achalasia may be also described due to lack of the Rictoanal inhibitory reflex, and tried at first we perform bowel management, however, or myectomy or myotomy. However, as this constipation is temporary, we try to use the chemical sphincterotomy using botulinum toxins or nitroglycerin paste. The ultra-short Hirschspurung disease may be described as a separate entity or may be part of the internal sphincter achalasia. So may be described segment A ganglionic less than 3 to 4 cm or part of internal sphincter achalasia. There is what's called dysmosis coli, it's very rare condition, may be described in isolation or associated with Hirschspurung disease related to lack of the connective tissue in the longitudinal and the circular muscle layers. There is something called megacystitis microcolon-intestinal hyperperistalsis syndrome. This is a very rare form of the neonatal intestinal obstruction that may be very similar to the Hirschspurung presentation, however, characterized by dilated, non-obstructed urinary bladder with or without dilatation of the upper urinary tract. These conditions is related to abnormalities of the smooth muscle disorder and generally diagnosed with biopsy and immunohistochemistry, and the outcome is generally fatal. Thank you very much for your attention. I think this is a very important lectures on the Hirschspurung disease. Hirschspurung disease, congenital and developmental disorder, absence of the ganglion cells from both plexus of the intestine with many other abnormalities in the adrenergic, cholinergic, and smooth muscles, abnormalities in the intestinal neuronal dysplasia, abnormalities in the proximal ganglionated part, abnormalities in the motility. Rectal biopsy is essential, intraoperative to perform frozen section, and to diagnose Hirschspurung and its variant. Start at first with intraoperative frozen section, absence of the ganglia, hypertrophied nerve, and the acetylcholine esterase staining. Then we may need to perform full thickness with immunohistochemistry. A child not doing well after Hirschspurung is very important, may be subjected to complication, persistent obstructive symptoms from mechanical obstructions, from error in the pathology, motility disorders, or internal sphincter achalasia, or functional stool holding behavior, or may be related to the presence of the fecal soiling, may be related to enterocolitis, may be related to the disease is variant of the Hirschspurung, is pseudo Hirschspurung, not true Hirschspurung disease. So please, this variant disease may be present clinically resembling Hirschspurung. Delayed passage of the meconium, abdominal distensions. You cannot differentiate based on the clinical presentation. Also, you may face this variant of the Hirschspurung intraoperative, as when dealing with neonatal areas obstructed, and you find collapse of the whole colon, dilated small bowel. Is this total clonic aganglionosis or variant Hirschspurung? Depend on the pathological examination. The intraoperative full thickness biopsy is very essential and taken from 3 locations: at the site of the calipary change and at the terminal ileum to diagnose this total clonic, and at the rectosigmoid to diagnose Hirschspurung disease. Perform stoma after taking the intraoperative diagnosis from due to the present or absence of the ganglion cells. This variant may be immaturity of the ganglia, ganglion immature, maybe hypoganglionosis, whether congenital or isolated segment hypoganglionosis. This with abnormalities of the ganglia related to disease, allied disorder with abnormal ganglia, immature hypoganglionosis or congenital generalized hypoganglionosis. However, we may have allied disorder with normal ganglion staining by the hematoxin and leucine and the acetylcholine strains. So immunohistochemistry is very essential, must be available in every hospital dealing with a child complaining from Hirschspurung disease and its variant. Sometimes pediatric surgeon operate a child with Hirschspurung disease, perform a stoma, and the stoma didn't work. And he cannot decide why this stoma didn't work. Maybe didn't work due to the diagnosis in the pathology is error, due to present of variant of Hirschspurung. The case may be intestinal hypoganglionosis, maybe congenital hypoganglionosis, maybe immaturity of the ganglia, maybe related to abnormalities in the smooth muscle, maybe related to intestinal neuronal dysplasia. So please, when dealing with a child with Hirschspurung disease, put the variant of the disease in your mind. Put the variant in the differential diagnosis as may present clinically by the same presentation or may present as operative challenge for the pediatric surgeon with ileus, neonatal ileus, and the finding of caliper change or even intestinal atresia or even some cases of the meconium ileus other than the cystic fibrosis may be due to immaturity of the ganglia of the intestine. So our understanding of the variant, our understanding of the recent immunohistochemistry tools is very important. No pediatric surgeon can diagnose Hirschspurung depending on the full thickness, not intraoperative, not performing acetylcholine esterase staining. Not well known that there is immunohistochemistry, there is S100 protein, there is CD56, there is some related what's called Hood C and Hood D immunohistochemistry, each one specific for diagnose certain disease like intestinal ganglion immaturity, like hypoganglionosis. If your baby is generalized congenital hypoganglionosis and you deal with as a Hirschspurung, as a total colonic, this is your knowledge that this is a total colonic aganglionosis and perform stoma, the stoma didn't work. You change the site of the stoma, every surgery with morbidity and mortality and the loss of the part of the intestine. Finally, you get a child with atrophic, non-functioning gut, and the only hope is intestinal transplantation. Thank you very much for your attention. I hope the lecture will be beneficial for every pediatric surgeon, everyone working or dealing with the Hirschspurung disease, the pediatrician, the all-included staff working with Hirschspurung disease. Thank you very much and see you later in next chapter of pediatric surgery made easy.